Thank you everyone for attending this afternoon. I realise it is pretty much kind of smack bang during lunchtime. So hopefully this will still provide some interesting learning during the lunch break. So like Dawn mentioned, this is all related to my PhD, which I'm coming to the end of now as I am just finishing up my thesis. And this title really has come from my systematic review. My PhD overall has been evaluating and looking at the NHS low-calorie diet, but I wanted to focus this presentation more generally on the views, perceptions, and also a little bit on the experiences of minoritized ethnic populations in regards to undertaking type 2 diabetes and obesity programs. So kind of firstly, it's important to have a little bit of background information about type 2 diabetes and obesity in itself as well. So you can see on the screen there, I have got some definitions of type 2 diabetes and obesity, which you can have a read through. I'm not going to read directly from the slides. So an individual is actually considered to be living with overweight or obesity if they're classified as having a BMI, so body mass index, above 25 or 30, and 23 and 27.5 respectively in people from South Asian, Chinese, other Black, Middle Eastern, Black African or African Caribbean family background. In regards to BMI, I do have to add that caveat in, I guess, coming from a dietitian background and research side of things, it can be quite arbitrary in terms of the BMI, and there is a lot of arguments for and against the use of it. The data originally where we came up with the 25 and 30, that came from a really specific male Caucasian population group from one country, and we've used it for so long, and actually research now has been telling us that it's not a great indicator, especially by itself. You might notice that if you, for example, if you had the BMI of somebody who's a bodybuilder compared to an individual who would be considered living with overweight obesity, they might have the same BMI, but actually the fat mass, the muscle mass, everything looks completely different. So in terms of BMI, yes, we do use it as an indicator, but it is important to know kind of there are the strengths and limitations to it. And there's a lot of critical analysis in relation to using it, particularly in individuals from ethnic minority backgrounds, because of the fact that actually more research suggests it's the waist circumference that's perhaps more important in terms of the fat accumulation. Obesity and type 2 diabetes don't affect all populations equally. There's a higher prevalence in older age groups, those living in area level deprivations, and in individuals from a Black and South Asian ethnicity. So when we're talking about South Asian ethnicity, I do feel like it's important to say what we're kind of referencing as we're sat based in the UK is those from the South of Asia. Because to those who are from a South Asian background, actually saying South Asian means perhaps those from South of Asian countries, not from us sat here in the UK. And that's something I've had lots of conversations with people about before, so I think it is important to caveat that as well. Type 2 diabetes is up to 6 times more prevalent in people of South Asian descent, and statistics show that 73% of Black adults lived with overweight or obesity, which is actually the highest percentage out of all the ethnic groups. And that's from the NHS England data from 2020. Individuals from Asian, African or Afro-Caribbean ethnicity are also 2 to 4 times more likely to develop type 2 diabetes compared to their Caucasian counterparts. South Asians are also diagnosed on average at sort of 46 years old, plus or minus 12 years. And in Black, African or Caribbean individuals, it's 48 plus or minus 12 years. That's quite a big difference compared to white Europeans who are diagnosed at an average age of 58 plus or minus the 12 years. So again, there needs to be some sort of questioning in terms of why are those populations being diagnosed or, you know, having diabetes at much younger ages, you know, a difference of about 10 years compared to the Caucasian individuals. There's also a significantly higher proportion of individuals from ethnic minority backgrounds developing type 2 diabetes before the age of 40 compared to European individuals. Individuals with type 2 diabetes, we also know, have an increased risk of complications, so a 2-fold increased risk of stroke compared to a general population. And the management and treatment of type 2 diabetes also brings an economic burden. So diabetes actually accounts for about 10% of the NHS budget, and 80% of those costs are due to the complications. The most comprehensive analysis to date actually concludes that the direct cost in 2010 to 2011 for type 2 diabetes was 8.8 billion, which again is related to those complications. A significant contributor to the risk of being diagnosed with diabetes is obesity, with data suggesting that obesity accounts for about 80 to 85% of the overall risk of developing diabetes. And it's estimated that the NHS and wider societal costs associated with both obesity and diabetes will continue to accelerate unless urgent action is taken. With that in mind, the NHS, the long-term plan, pledged to provide targeted support and access to weight management services in primary care for those with a diagnosis of diabetes and a BMI of over 27, which is adjusted based on ethnicity, as I've mentioned. And the aim of that is to improve health, reduce health inequalities, and to cut those associated NHS costs. So that provides a little bit of background in terms of the obesity and type 2 diabetes and a little into ethnicity. But actually, we need to discuss more in terms of how it's a public health challenge and the fact that these interventions that exist may be effective for those who participate, but actually research shows there's a high level of non-adherence or dropout rates. And also there is varying statistics in regards to the uptake by different population groups. If the targeted population is not one, joining the program, or two, dropping out, actually that could lead to widening inequalities. And there needs to be an analysis in terms of what's causing that and what can be changed. So despite that increasing kind of implementation of weight management and diabetes prevention programs, there's a critical gap really in understanding how the interventions are perceived and experienced by different ethnic groups. Research has shown that participants' views, experiences, and perceptions influence their motivation to continue with and to follow the advice within a program. For instance, if a program is perceived as culturally insensitive, if it's not aligned with personal values or fails to address specific needs, participants are more likely to disengage, leading to higher attrition rates. On the opposite end, when participants feel that a program is culturally tailored, it's individualized and provides meaningful support, adherence is generally improved. Previous studies have demonstrated that increased attendance and decreased attrition lead to improved outcomes for weight management. So outcomes generally in studies are things like weight, BMI, waist circumference, but it can also be related to behavioral support, psychological support. There is therefore kind of that urgent need to understand the factors that might reduce the attrition rates among these underserved populations, such as minoritized ethnic groups, which is recommended by the National Institute for Healthcare Research. In considering all of this, it is important to note that the food practices are not homogenous. They vary not just by ethnicity, but factors such as religion, age, generation, income. If we think more now, I guess, work-life balances as well, families, livelihoods, there's lots of different things that are impacting those food practices and choices. So how do we consider to make the support that we're providing individualized? How does the NHS or community practices serve this wide, population group that we have? And actually, alongside ethnicity and culture, which are very important, behavior change, barriers to an individual, which aren't just related to a person's ethnicity, are really important to consider because they would also impact an individual's success and compliance. So, for example, if a program is delivered online versus face-to-face, the timing of a program, if they have children, the timings of school drop-offs and pickups. So determining the causes of all of these inequalities is very difficult. There's lots of factors which influence the prevalence of type 2 diabetes. So there's a lot of, in terms of the context of culture, environment, the wider social context in terms of racism or genetics, and also services in terms of healthcare. I think all of us today can understand that there's a lot of pressures at the moment on NHS's services, staffing, whether that's from staffing or the service that's actually being provided, the time allocated for appointments, the services that are able to be delivered. All of those would have an impact on an individual accessing such services. There's a higher risk, as I mentioned, for certain ethnic minority populations in terms of the obesity and type 2 diabetes. And the main pathophysiological processes underlying type 2 diabetes development are well documented, and they focus on the role of obesity, visceral and ectopic fat accumulation, insulin resistance, and insulin secretory. The previous BMI cutoffs, as I mentioned, were based on white populations, but used globally. But they didn't account for all of those differences in body composition, the health risks, which could lead to a potential underestimation. There's also growing evidence indicating that actually Asian population tend to have a higher prevalence of type 2 diabetes at lower BMI levels compared to those white population groups. Furthermore, there's research that has established that while increasing body fat content is linearly associated with insulin resistance, fat distribution, particularly abdominal or visceral fat, is more accurate predictor of insulin sensitivity than BMI, especially as diabetes is more related to the insulin side of things. But there are barriers which influence how much a person is able to access these services or actually get support with any of those. So things like language differences, socioeconomic status, potential biases within the healthcare system, they can all kind of impede that timely and effective care to someone accessing services. Those from ethnic minorities may encounter difficulties in navigating the healthcare system, understanding medical advice, and adhering to treatment plans. Research has shown that individuals from non-white European ethnic backgrounds often experience poorer diabetes knowledge and worse diabetes control due to language and cultural differences, poor health literacy, so poorer understanding of actually their own health, and low socioeconomic status. And their migrant status actually makes a difference as well. So if they're first, second, or third generation in the country. The cornerstone of diabetes care is self-management programs and diet, lifestyle advice, which don't tend to include tailoring, tends to be less effective in these populations. So when we're discussing the factors influencing the prevalence, how an individual is able to access these services and what services exist, the main concept we're talking about here is health equity, which is the fair and just opportunity for anyone to be able to seek help, regardless of their background, social position, or any other factors. So that hopefully provides a brief overview in terms of the type 2 diabetes. And now moving more critically onto the overview of the methods that I've utilised in my research, which has led me to the themes which we'll be discussing shortly. So I've amalgamated all of my studies together to come up with the themes. So firstly, I completed a systematic review, which looked at the views, experiences and perceptions within those programs. I then completed interviews with participants from a South Asian background who have undertaken the NHS low-calorie diet program. The low-calorie program is a year-long intervention in which individuals first complete 12 weeks of a low-calorie diet, which is in the form of total diet replacement, where they receive soups and shakes. They then have weight maintenance stage, where they also receive support in a group format typically. And due to COVID, it was all delivered online in regards to healthy eating, exercise, and making changes, followed by the last stage, where they had less regular support, but still had that access to a health coach, for example, in terms of what to do. I then also undertook interviews with coaches who were delivering the program. They were either from an ethnic minority background themselves or were delivering the program to those from a minoritized ethnic population. So the themes. These are mainly the themes from the systematic review. So family health status and program education as motivators for program uptake and adherence. I have just pulled a couple of quotes which you can see on the screen as well, which I think really help to highlight where that theme has kind of come from. So the family health status, that's family members with health problems. They acted as a motivation for individuals who didn't want to go through the same experiences, and individuals described as wanting to take care of their health. to complete these health-related programs to support their families. And they worried that their own health could actually worsen if they didn't make any changes. So gaining an understanding and knowledge from the program through the educational sessions and practical application, such as understanding the nutritional value of foods, acted as a big motivator for them. Education and knowledge also encompassed program-specific activities, such as keeping a food record at home, and that supported the application of knowledge and the accountability to changes, because they were recording actually what they're writing and seeing it down on paper and then having to take that in to the health coach, for example, or dietitian. It gave them more of that accountability. Meals also supported the dietary adherence, especially where in programs it was provided for free, and reduced the barriers from a household perspective in making changes. Social support was a large theme in making and maintaining positive changes during the program. So this social support came from family and friends, in regards to, for example, family members encouraging them to attend the program, or at home in regards to, okay, this is what you learned about, this is how we can make the changes. In some examples of the interventions in the systematic review, some of the studies, the participants actually had the family members attending the program with them, and that really helped to bolster the advice as well, because it had another person who could say, oh yes, we learned about this, this is the difference that it makes, let's do it together. There was also a big impact in regards to the peer support. It supported the program adherence, and participants said it helped to raise their self-efficacy as well. They were able to communicate and talk with each other, share recipe ideas, share what they're currently doing on the program and what is working. Particularly where they had support with others from the same ethnic background, that seemed to be of even more importance and even more help. I do apologise, the sun is shining very brightly now on my face, so I'm just going to move around a little bit. Staff, health coaches who were from the same ethnic background were able to understand the cultural background of the individuals and perhaps tailor the advice more easily, which had a positive impact. But there were challenges which were created in managing the diabetes programme and staying on to the adherence of it. So environmental challenges included making dietary changes, so physical resources such as access to gyms, lack of cooking skills in terms of actually incorporating the changes that have been provided, and also dietary preferences and cultural beliefs, which resulted in food-based challenges such as disliking the programme provided food and the food flavours being outside of those cultural norms. Healthy foods were also viewed as being more expensive, and in some households, not all the family members would eat the same foods, which resulted in those individuals having to buy separate foods, separate meals, which again was increasing the cost, made it difficult to actually sustain longer term. And some studies therefore found that programs which provided the financial support or free meals received positive feedback because they reduced the financial burden of participation. So it just reduces those barriers for individuals. Cultural beliefs impacted on experiences of the program. So they described their own pre-program experiences of health and health beliefs, which included kind of their understanding of diabetes and how they felt it negatively affected them. Some of those health beliefs were tied to socio-cultural beliefs, such as gendered employment norms, that perhaps husbands need to go to work, women need to stay at home, and that in certain cultures, so there was a particular study in which Latino women in the US would be considered selfish for looking after their own health, for putting that first above the family and others. The programme delivery by staff from a similar culture also increased not only participants' comprehension of the educational materials, but also their comfort in sharing cultural related challenge in diabetes management and strengthened the relationship and rapport. Having said that, one of the studies in the systematic review did report that actually the ethnicity matching didn't really have to matter, or didn't have to match, as long as the providers were able to show cultural competence, were able to show that understanding and tailor the delivery accordingly. There was an increased awareness and positive dietary changes during and following the programme, that actually following the programme, they had that increased knowledge specifically through, for example, food portion sizes, what are the healthier choices through the education that they've received on the programme. And those healthier choices were often described as consuming less fat, less sweet foods, and eating more vegetables in the diet. So a lot of that centres around the Eat Well UK government Eat Well guide. Participants in the studies also described wanting to medically manage their health and type 2 diabetes through blood glucose monitoring and having that understanding of the diet. So they wanted to have that independence in terms of what they need to do. So just being taught it, but then being able to apply it at home. Psychological evaluations was quite a large part of it. And I think we can all understand that actually anyone undertaking any sort of health program, there is going to have a psychological impact to it, particularly with obesity and type 2 diabetes, where there's potentially already that impact if there is any disordered eating or anything like that. So studies that focused on the psychological constructs to describe program impacts reported there was an increase in self-efficacy and self-motivation. And self-efficacy was actually described as an important factor in adhering to a diabetes meal plan, and also goal setting as an important technique. So particularly that focus on SMART goals, so that individuals, when they go away from a session, know exactly what they need to do, how often, what days of the week, to make it easier for them to actually stick to what they need to do, rather than everybody just having the same sort of goal of, okay, everybody's going to do this. Having their own individualized one made it easier to actually put it into place and to achieve it. However, one of the studies did find that individuals may struggle with that goal setting and the self-care if too many goals are set at once, therefore suggesting a need for gradual change. So if you are setting a goal with your participants or individuals, actually you might want to begin with one goal, then maybe two goals, and wait until some of those goals are being achieved before moving on to the next ones. Because if you provide all the goals all at once, it makes it really challenging and increases the barriers for someone being able to implement that. Programs targeting the psychological constructs such as self-empowerment and self-efficacy through techniques such as the goal setting and coping skills training help participants to actually replace a negative state of mind about their diabetes management with more of a proactive stance. And they were able to take more responsibility for their self-care and in making those changes themselves. So what considerations do we need for future programs? One of the papers did emphasize individuals' desire for further education on the long-term impact of diabetes on health and the importance of making changes, which again, with individuals having that information of why it has such a big impact and longer term, it can help to support them with making changes. Other suggestions for improvement included the program structure. So, for example, related to the timing, the frequency of the intervention, the venue, the recruitment process as well. And that's quite a big one because there's a lot of research to suggest that it is difficult to recruit participants from, for example, lower socioeconomic backgrounds, diverse ethnicities, certain age groups. So perhaps considering how the recruitment is taking place, are we accessing the same services that those individuals would go to? So, for example, places of worship, schools, just considering how the message is going out there for them. Proposals included having longer sessions but reduced frequency, use of non-clinical community venues such as the faith organisations, and also tailoring the programme advertisement to enhance the reach. So in regards to social support, that was a really big theme that came out of all three of the studies. I have used a triangulation methodology to pull kind of the key findings from all three of the papers together to bring this in. So the group social support was really important and it matches with other research. So there was a narrative review by Patel et al. Back in 2017, which found that cultural expectations such as the importance of serving culturally relevant foods and also the expectations of family and the wider social circle were barriers in making dietary changes. In this review, it did only focus on South Asian individuals, so it may not be generalizable to all of the other minoritized ethnic groups. But nevertheless, that research is supported by other data from systematic reviews, which has shown the importance of families in maintaining dietary changes for type 2 diabetes management at home, and the barriers presented by social pressure to eat during events. So for example, weddings or parties or any functions. Similarly, there were common barriers to a healthy diet, such as a lack of awareness, general misconceptions of a healthy diet, alongside those competing cultural expectations. And I suppose it's important to note that those competing social and cultural expectations would vary for each person based on each culture as well. It's not homogenous when we're talking about, for example, even within South Asia. There are so many different ethnicities, so many different backgrounds, subsections, each with their own experiences, their own cultures. So it would actually need to be tailored according very specifically to that, and how we can actually maintain that where there's so many. Access to services. So previous systematic review, which actually explored the barriers in facilitators in accessing these services, found there was a of the services to begin with. There were concerns regarding the appropriateness, the care processes, and the quality of care. All of those are shaped by the social and cultural factors. This review did have a variable study design and outcome measures, so it does make it difficult to directly compare the results or draw conclusions, which could kind of limit the strength of the evidence. However, the access to services in my studies did find actually that there was difficulties in accessing local gyms, or some of the participants maybe mentioned wanting a female-only gym or exercises, where to access that. And where programs are delivered online, it might be that the health coach is not based in the same area as the participants, or the participants themselves might be dispersed in different areas. So how do you provide the advice when you don't know the area itself? So cultural tailoring in education, this was probably the biggest theme across the board in terms of participants feeling there was a lack of cultural tailoring, or actually the cultural tailoring that was provided was made across, for example, Ramadan and products being halal. There was nothing more in terms of, oh, how do I manage certain expectations or challenges that they come across? These deep structure and surface level adaptations have been cited in literature. So the deep structure or deep surface adaptations are an understanding of the social and cultural factors and the use of social support, family involvement, and that co-production of materials with target communities are thought to increase the intervention, adherence, and success. And actually, a lack of understanding of cultural norms and beliefs by programs could impede ethnic groups from accessing and adhering to those programs. The themes identified from the review were participants' strong adherence to culture, different beliefs about health and illness, and low acceptability of those culturally appropriate services. Lack of cultural understanding by program providers has been highlighted as a barrier in engagement, especially those with obesity-related concerns. It doesn't provide perhaps the practical, culturally appropriate dietary advice, and health professionals are sometimes giving contradictory advice due to that lack of awareness of the foods consumed in terms of the cooking methods, for example. And there is perhaps a perception that eating your own ethnic foods is considered more healthy, and there's a bias towards having Mediterranean diet. But for someone who's eating, for example, chapatis and curries, asking them then to switch to, I don't know, jacket potatoes or some form of salads, it's so far away from what they're currently eating to what the changes are. So it's how to balance that and meet somewhere in the middle. There are lots of examples of good practices in the UK as well in regards to diabetes and weight management programs. There was an intervention in 2016 which targeted South Asian populations, which embedded health ambassadors that provided educational sessions, and there were bilingual individuals actually delivering those sessions as well and tailoring it accordingly. So when individuals had a question, they were able to actually answer it and tailor it at the same time because they had that cultural competency and reduce the barrier of language. So it is important to be kind of sensitive to the culture, maybe involve faith leaders, training programs to those delivering the intervention as well. In regards to dietary advice, as I've mentioned, actually eating habits, dietary decisions, they vary between ethnic groups, not just now, but over time and with changing circumstances. So the varying dimensions of an individual's lived experience and diversity within those broad ethnic categories should be considered in the design of those tailored interventions. And it's considering the ingredients by themselves, but also the cooking side of things and how it impacts on a family. In regards to programme modification, co-design involving active collaboration between healthcare providers and communities allows for the development of services that are not only culturally sensitive, but also responsive to the unique needs and preferences of specific ethnic groups. So working with the individuals that this programme is targeting in coming up with the programme or what the programme should look like helps to actually enhance the programme delivery and success. So implications for future research and practice. So future research is needed to understand what helps to improve the referral, the engagement, adherence, and the effectiveness of type 2 diabetes and weight loss services, particularly for minoritized ethnic populations, as there is a lacking of research and studies in regards to those populations. And actually, a lot of the studies that have been undertaken have been in countries such as the US. Future health policies should be aimed towards improving the cultural competence training to facilitate the partnership between individuals and their healthcare providers. The responsibility does have to be shared. It's not a blame culture. It's actually right from the top, making sure that individuals who are working within such interventions, such programs, they have the training and support to be able to deliver the program, to be able to answer those questions, or where they're unable to, have access to other individuals, to online resources. So for example, I mentioned the Eat Well Guide, which is the UK's national recommendations for eating and drinking and following a healthy diet. That's based behind a Western diet, but actually with some research, you can find a South Asian Eat Well Guide, a Caribbean Eat Well Guide. So actually it's the importance of individuals being aware that such resources exist and being able to utilize that to be able to support the patients and the clients in the best way possible. And also just considering the factors that are really important to the participants. So social support can be both a challenge where it comes into the social cultural side of things in terms of eating out or family pressures, but also it can be seen as a positive in regards to the fact families can help with making the changes. So how does that balance and how can that be provided within program implementation? Considering that actually in certain cultures, it might be that there is holistic or, for example, Ayurvedic practices. How does that tie in with kind of the advice that's being provided and how can we support those individuals? There were strengths and limitations to my studies. A lot of those strengths were the gold standard methodology, that we had dual screening for the systematic review, but limitation was, as I mentioned, a lot of the studies were based in the US, and also the fact that it was quite homogenous in regards to the data, the population set. You can't kind of apply it across the board. So again, just a really brief summary of the other studies and how they tie in with everything that I've just mentioned. So with the interviews with the participants, they were my key themes. Again, you can see how they directly link with my results from the systematic review in regards to the relationship with the coach, social experiences, culture, with everything that I've just mentioned. I wanted to just do a page with some quotes as well, because I did think it was really important to give an idea of what the participants actually said in interviews and how that ties in with the results side of things. I think it's quite interesting, one of the quotes, that they stopped eating the traditional food. So for example, chapatis, that it's almost like a food has been villainized, when in actual fact, it's just part of the cultural side of things. And we need to look at what are the portions of that food. What are they adding on top of it, for example, rather than saying you just can't have chapatis. That would be, I guess, vaguely similar to saying that you wouldn't be able to eat bread anymore. And again, the social side of things, that they avoided going to social events because, particularly when they were having the total diet replacement of the soups and shakes, they felt uncomfortable taking those out in public places, or in actually stating to family members or friends, oh, sorry, I'm on a diet, I won't be able to eat and drink. And they felt there would be some pressures in regards to that it's maybe being disrespectful to not accept the food and drink that's being offered at these specific events. In regards to the coaches' experiences, because we've had the participant side of things, the coaches was very similar in regards to, with cultural tailoring, that they struggled with it. They weren't sure what that encompassed or what resources that they could access. an impact of language, where participants couldn't speak the language and maybe had an interpreter who was a family member, but it meant that they couldn't actually keep up with the education side of things, because as quickly as it's being taught, they're trying to translate, so the participant still isn't getting 100% of the information. A lot of the coaches mentioned that they wanted to understand the impact of culture and ethnicity. Some of the coaches, mentioned not actually knowing what does it mean in terms of ethnicity, what do we mean by South Asian, for example, and wanting to broaden their horizons with that. And they identified their own training and support needs in being able to serve a broad population with programs such as this. Again, just some quotes to highlight some of those things. So you can see here, as I mentioned about the chapatis, where the participants are cutting it out. On the opposite side, the coaches mentioned that they recommend cutting down on chapatis, and that's where the advice is coming from. But there's a lack of that cultural awareness and understanding, which is leading to advice such as this. And to conclude, for these programs to be effective, it's really important that programs are sensitive to the needs of the population group, and also that it is implementable within the community. There needs to be a consideration of social, habitual, economic and conceptual factors, which include the consideration of the local ethnic and cultural norms and the community relationships that facilitate the creation of these programs, which are co-designed with the target communities in terms of working together. In terms of for policy and practice, it would be making sure that the advice information is affordable, it's culturally sensitive, and it takes into account all of those different contexts in terms of religion, health, beliefs, the co-production of the materials and also the design, peer support in regards to family members, friends attending programs or how that could look like, and also a focus on overall well-being rather than just outcomes. When there's a focus perhaps just on, well, what is the weight? How is the weight changed, for example? It can lead to increased mental pressures on an individual, and it should be more about how do they feel within themselves, for example, in terms of maybe the energy wise. So when I did my interviews with the participants, one of the participants did mention that, for example, from doing the program, she now could pick up her child from school and walk the child back as well at the end of the day. And that made a massive difference to their quality of life. But that's not something that would be picked on if the outcomes were just, what has the weight changed? What are the differences with kind of the quantitative measures? Actually, there's a lot more to it than that. And where there is total diet replacement products, this is me just very briefly talking through some of the results. There's a lot more to it. But for example, there was a lot of reports that those products were not well suited at all. It didn't match in terms of the flavor profiles, that it didn't have much taste to it. So a lot of the participants were actually adding salt, spices, herbs, anything possible to make it more palatable for them. So actually, does there need to be a consideration of the products that are being provided? Things like herbs, spices and salt, well, they're not really contributing in terms of from a diabetes or obesity perspective. The food can still have flavour, and how can that be tailored to be able to suit a more wide, diverse profile? But actually, that's something that we may find across the ethnicities, including Caucasian groups, because anybody would want perhaps flavours in the foods that they're having, how to make it more tolerable for that period of time. That's everything from me in terms of hopefully a very quick overview of the research that I have conducted. I'd be more than happy for my email address to be shared if anyone is interested further, as I've only had so much time to kind of go through those key points with the findings. So I hope that's provided a helpful overview.
Thank you, Pooja. That was really thorough and well articulated presentation. And yeah, thank you for highlighting the importance of that cultural competence and also giving practical tips and how we can implement that into our practices as researchers and as clinicians. Really, really interesting and really, really important work. Yeah, so thank you for that. So I don't think there was any questions in the chat. Does anyone have any questions for Pooja while we're here? You can unmute yourself and ask your questions if you have any.
Hi Pooja. I think you can hear me. My name is Tiago, and I work for Roxanne, and it's very interesting to see how this tailored approach really does contribute to a higher adherence and better outcomes for the patients. And I particularly like what you mentioned at the end, that we are very careful at setting goals that are tailored but also non-weight related, about the quality of the lifestyle and how they're able to feel more energy, be better fit, and just summarize everything that we're doing. And it's very nice to see that this is now being considered in NHS as well.
Yeah, absolutely. Thank you so much for that feedback as well, Tiago. I think we do get focused sometimes, particularly in the NHS. I worked in the NHS for a long time, on kind of those outcomes when we're seeing patients, for example, in clinics or in services, in regards to asking them, okay, so what's your weight now? What's your BMI now? And sometimes we can lose sight of actually it's not just about that, especially for the participants or the patients. It's more about how are they feeling within themselves and how can we support them with the goals that they might have. Their goals might not be to be a BMI of, X, or to have a weight of, Y. Their goals might be to be able to walk up and down their stairs of their house. How do we help them achieve that side of things? And taking, I guess, more of a holistic perspective in terms of understanding our patients and clients.
Yeah, totally. Thank you. Thank you for this.
Thank you.
Okay, any more questions, feel free to put your hand up or unmute. If not, and you think of any questions later, feel free to email them in and Pooja would be happy to answer them online or on social media. So if that's it, thank you again, Pooja, for that excellent presentation. It was really wonderful to hear about your work. And yeah, thanks so much.
No problem. Thank you all so much for having me as well.